Welcome and mazel tov.
Thank you, Aidel. It's truly so good to be back. We haven't been on the radio for quite a while for now. I mean, we were away, December, so much going on.
Yes, maybe now you think it's quite a while just because you don't know the difference between day and night right now feeding your baby. It's good to be in the swing of things, and we wish you a heartiest mazel tov. You should have lots and lots of nachas.
Thank you so much. Thank you. You truly are blessed.
Indeed, indeed. And just talking about babies today, we have a very exciting show. We are honored to have Dr. Gobetz, who's going to join us. Dr. Gobetz is a well-known name in South Africa. He received his medical training. Here he's a fellow of the College of Obstetricians and Gynecologists, and he is recognized by the South African Health Professionals Council as a reproductive medical specialist. He's been around since February 1990 and also did postgraduate training in the United Kingdom and Belgium. And of course, his interest is in the evaluation and treatment of the infertile couple, recurrent pregnancy loss, PCOS, endometriosis, male infertility, and the effect of spinal cord injuries on fertility. So we have a lot to speak about. If you would like to ask Dr. Gobetz any questions, you can SMS the line on 34519, or our telegram number is 061-895-1019. Without further ado, Dr. Gobetz, welcome to the show.
Thanks, Aidel. It's lovely to be here with you. Hi, Faygie, mazel tov, and hope you're getting some sleep.
Thank you so much, Dr.
Hope
Gobetz.
you're getting some sleep.
Yeah, with Aidel advice, I'm getting there.
I said to Faygie that, you know what the problem is that you raise your kids, they're all experiments, and so you experiment on all your kids, and by the time you finish, then you know what it is that you have to do, but then it's too late because the experiments are over.
But there's no experimentation, Aidel. In my days, my mother had a book called Dr. Spock, and that book told you exactly what to do. This was in the 50s, so I'm just giving my age away, but yeah, there are manuals out there, you know.
Look what happened. I was a Dr. Spock baby. Look what happened.
I think in this day and age, there's just too many opinions. That's the problem. We don't know who to turn to.
Yeah.
And that's why we're running the show, because we want to educate people. We want to empower people to live healthier lifestyles. So to kick off the discussion, Dr. Gobetz, you know, it seems that the trend of infertility is certainly on the uprise. You know, maybe 25 years ago, was it because we were uneducated and people just went without? Or are you seeing a difference in your years of practice that more and more people are needing infertility treatment?
Yeah, you know, we quote infertility as, I mean, firstly, if we define it, it's also a strange definition, because you say, well, if the woman's under the age of 35, the couple should at least try for a year, and if the woman's over the age of 35, you should try for 6 months and then go and seek help. So that already says one thing. It says, obviously, we need to be aware of the older female. And I always say that in my day when I grew up in Benoni, my mother had a half-day job together with all her friends. They helped GPs and accountants and lawyers, and then they would play poker in the lounge in my home in Benoni, and you couldn't see that they were playing poker for cigarette smoke, which we can discuss. And at the end of the day, everyone sitting around that table had 3 kids by 22. And today, the reason behind why we are seeing more infertility is because the average age of a female setting out to start her family is much older. And there's a big difference in a male versus a female, and how the ovary works in relation to how the testicle works. So that's our biggest problem. But across the board, you would look at it as being about a 10% incidence. And it doesn't matter whether it's race group, nothing makes a difference. Everybody has the same incidence. So, but definitely, if we look at the average age of the woman coming to us now versus 15 years ago, the average age of the woman has skyrocketed upwards in excess of 36, 37 years old at the time that they want their first baby.
So age is a major problem. What is the percentage of people that are planning in advance, knowing that they want to only have children when they're later, at a later stage? And is that also a better option to freeze eggs, in advance?
Yeah, so, the most important thing today is that females will complete their schooling. They will then go to university, and often it's not 1 degree, it's 2 or 3 degrees. And by the time they then settle down and find Mr. Right, and sometimes today after 5 years Mr. Right is Mr. Wrong, and then they're 38 or 39 with the second Mr. Right. So our main issue is I'm not saying that women shouldn't do this, but what Faygie is saying is, and it's a very important factor, is that unless you're told biologically how your ovary works, and the fact is that women are unfortunately given a genetic age at the time of their fertilized egg becoming them as an embryo, and that genetic age is a basket of eggs in their ovaries which do not make new eggs, and those eggs are programmed to die off. So at the end of the day, a fetus at 20 weeks in a mother's womb has got 6 million eggs, and these studies have been done from fetal studies. At birth, the average fetus has 1 million eggs. I'm talking about a female fetus. At puberty, take rough age 12, 13, that same, both ovaries now only have about 300,000 eggs. And what happens is, as the woman gets older, so does her ovaries get older, her egg basket gets older, and her egg basket gets less and less because those eggs are programmed to die off. So as you get older, a woman of 38 does not have the same monthly potential as a 21-year-old. And our understanding of ovaries is that the ovaries usually at its peak somewhere between 16 and 26. And after that, one goes on the downhill. But interestingly, the earlier you start conceiving and the more you continue conceiving, you will be able to continue conceiving probably into your mid to late 40s. But if you've never had a conception and you now start out at 38 or 40 or 42, you're going to have immense difficulty. So somewhere along the line, the pregnancy itself at early days and ongoing continuous conceptions seems to be a protective mechanism within the ovary. But the longer you wait to have that first child, the more difficult it is going to be. And we are faced today with this modern society of women trying to, get their degrees behind them, get money in the bank, then find Mr. Right. So, Faygie, you were highlighting the fact that could you put your fertility preservation, or could you put your fertility on hold? And today you can. So we can freeze eggs, and the best time to freeze eggs preferably is under 32. But if you only wake up now and you're 36 and you want to freeze eggs, we always say 12 or 15 eggs in the bank are much better than no eggs in the bank. But the earlier you freeze, the better. And currently egg freezing is relatively young, not experimental. We run our egg bank on frozen eggs and get very good pregnancies, very much similar to fresh eggs. So our technology really only became robust for freezing eggs at about 2013, 2014. That's the best way of doing it. But also to know that when you freeze eggs, and let's say we have 20 eggs in the freezer, 20 eggs does not equal 20 babies, so you don't have 2 soccer teams. And we can explain that later why. What does that mean? And the other thing is, it doesn't mean because you've frozen eggs you're not going to try on your own. And only if you don't conceive on your own will you then rest on your frozen eggs. And interestingly, those frozen eggs give the patient the same potential as what her age potential was at the age that she froze her eggs.
We're listening to Dr. Lawrence Gobetz, and we are having a discussion on fertility, infertility. If you'd like to join the conversation, 34519 is our SMS number, 061-895-1019 Telegram number. Well, this is the Healthy You, Wealthy You show. I'm Aidel Kazilsky with Faygie Sztern, and we are in conversation with Dr. Lawrence Gobetz, and we've started discussing the fertile range that a woman is in. Doctor, is there different types of infertility? Like, can we classify infertility into different boxes, or is infertile?
No, well, we say, firstly, if you look at it from the gender point of view, what percentage are male, what percentage are female, and then what percentage are combination. So when we teach the students, it's much easier to remember things in thirds. So we say usually about a third is a female, third male, and 1/3 is a combination. So then you've got to look at the issues of male infertility. What could the reasons there be? And that could range from anything from a normal sperm count, but the sperm lacked the ability to fertilize the egg, to a subnormal semen analysis where you're going to need to assist the couple, through to there being no sperm in the ejaculate, and there are many reasons for that. And today we get sperm directly out of the testicle, and we inject single sperm into eggs with a process called ICSI and achieve live-born babies. And then you look at the females. So the females would start off at, and as I say, I go back and I would start first at eggs. Then you would look at pathway. Is there a problem with the womb? Are there abnormalities in the uterus? Are the tubes open? Are the tubes blocked? Is there perhaps problems within the pelvis? Maybe there was a sexually transmitted disease that disturbed the anatomy and the tubes can't pick up eggs. The tubes are like creepy crawlies. They have to go and cover the ovary to pick up an egg. And, an egg is microscopic. It's 0.0125 of a millimeter. You can't see it with the naked eye. So if that tube cannot cover the ovary to pick up the egg, that patient's not going to fall pregnant naturally. So, and then at the end of the day, it could be a combination of factors. It may be a 41-year-old who's got 3 eggs left, and a male who is perhaps 49 and he's got 5 sperm, and you can give each one a name. They're in big trouble. So each couple is different, and you have to look at the problem holistically. For us, to look at the male is, and if we talk of it from a halachic point of view, it's quite simple, because we can scan the female, see when she's ovulating, and we can get them to have intercourse, and the following morning we can extract the mucus from the cervix, and we can see, is there sperm in the mucus? And from that we can get a really good idea of what the sperm is like. So from a halachic point of view, we address those issues within our unit at Vitalab, and we make sure that that aspect is covered for our patients, because that's one of the things that they get scared of. They think, well, you're going to a unit where they don't understand the halakha, and how am I'm going to be forced to do things which are not supposed to be done. So we're very sensitive to that. But yeah, at the end of the day, 1/3, 1/3, 1/3.
So then the question is this: if we're all blessed, well, lots of us are blessed with young daughters, that are going into puberty, that are obviously going to take the path into womanhood and motherhood. Are there specific things that you could suggest that young women in their adolescence years do, or maybe it stretches back even earlier than that, that will help ensure or give the ability for the girl to have natural pregnancies? Because a lot of the time you listen now today, with the milk, the hormones in milk, for example, or medications, and all of these things affect obviously the child as they're growing up. Like what would be the good pointers for mothers to know, not to do, or maybe to do with their daughters, to ensure that they have the best, the ability to have children naturally?
It's a very good question, but the answer to that is a crystal ball, because at the end of the day, 90% of couples don't have a problem. And they drink milk out of plastic bottles, and there's polyphenols in the water and a whole lot of other thing in the meat and this and that. They don't have a problem. So the patients that look at that is that 10% that now end up with a problem, because they've lost control over a very basic element, and that is just to close their doors and fall pregnant. Now suddenly they've got to seek help. So now they suddenly say, well, I better clean up my life, because it says I shouldn't smoke, I shouldn't drink, I shouldn't have too many sugars. Now I should really be on a Mediterranean diet. But why are you going to drive these young girls crazy, okay, at a stage of their lives where they're probably quite embarrassed about talking about things like periods and eggs and having to worry about conception, when they're not looking at boys at that age and not even thinking about getting married in the near future. So the question that we want to try and answer is, can we determine maybe genetically, which females have an egg age that's way in excess of their chronological age. And then you can select out that group and say that when they get into their early 20s, they should put their eggs in the freezer. But if we look at it and we say, you know, just get on with your lives, and there is really nothing else to do that's going to make you more fertile, because you could be superbly fertile as a female, as I said, and marry a man who's got 5 sperm to his name. There's nothing wrong with you. So I think we've got to be careful to drive the population crazy about how do I now make sure that I empower myself and keep myself fertile. The one issue is, get married younger if you can. If you can't, and you are now in your late 20s, early 30s, consider seeing a good fertility unit that gets good results with frozen eggs, and go and talk about egg freezing. And just interestingly, if we look at the data now from when we started to freeze eggs robustly and get pregnancies, there is no more than 20% will come back to use their eggs. So, you know, a good 80% of those patients are going to fall pregnant naturally.
Is that almost like they don't have that anxiety thinking that they're going to fall pregnant? Like, they know that there's an egg waiting for them, they kind of relax, they know they can fall pregnant naturally if they wanted to.
Yeah, it is. It's you know, it's like having an insurance policy on your life. But not every woman is going to, even though you tell her that, she's still going to make an informed decision and say, you know what, I'm not going to freeze my eggs. But at least she was counseled, at least she was given the opportunity, but one needs to counsel her in many ways, because, you know, so as I said, you can't think because you got 20 eggs in the freezer that you got 20 babies. 20 eggs in the freezer from a 28-year-old today would probably give us 2 babies.
Aidel, I think that the concept of anxiety comes in here, you know, where we overanalyze, we overthink, we make ourselves crazy for no reason because, I don't know, we don't have the correct knowledge, or, you know, we haven't sought the right help. You know, there's obviously a lot of anxiety, Dr. Gobetz, that you deal with on a day-to-day basis with women. And if you can just help us explain, how does anxiety, you know, with falling pregnant, whether it's with IVF or naturally, play a role?
They are very anxious people. Our patients really, they've often been through the mill. And, you know, it's a question of, does stress affect fertility? And if we look at the literature, and we look at the proper literature, and you look at people like Professor Jackie Boyven from Boston, literature, reams and reams of literature that show that the basic day-to-day stresses don't affect you. I think, and I've seen it in my 32 years of reproductive medicine, you see patients who get themselves into an emotional spiral. And I really believe that, you know, we all have a subconscious, and our subconscious, I believe, is the strongest organ in our body. And unfortunately, a lot of these patients go through very negative experiences. And I think that they have their own way, you know, in light of the stress of the infertility, that they get that body into such a tight spiral that they don't want to experience a negative result, and therefore somehow are inhibiting their ability to conceive. So we do believe that counseling is very important, and especially, and we can see the patients, you know, you can see those that are really taking strain, and the first thing I would do is, before I even look at the sperm count, rather send them to a counselor, because until you unwind that aspect, you're fighting an emotional side of them that is definitely negatively impacting. You know, I get patients that lean over my desk, look me in the eye, and they say, Lawrence, I'm leaving here pregnant. And you know what? They leave pregnant. And then you get other patients who you can see from the start, this is going to be an uphill battle. So, you know, we have many aspects. It's not just about male factor, female factor, combination of factors. We have a couple who have gone through serious pain. I had a call this morning for help from, and she's 46 now, and she has gone through the mill. And the only reason is I know her because I worked with her quite a few years ago, and she's absolutely desperate. Her marriage is almost on the rocks, and she's just going nowhere. So, you know, I've said to her, fine, let's give you an opinion and let's see how we go. But you can see how devastating it is, and how it's a death, you know, that these patients experience a death, and every time they have another period, they mourn the death of the pregnancy that should have been there. And this goes on and on and on. And let me tell you, after you've done it a few times and you've done negative IVFs one after the other, each time there's a negative result, you're just hammering this person further and further into the ground, you know. So we have to be aware of this. So the holistic approach is very important. And yeah, I think we've got to be careful, because there are people who conceive in times of war, okay? There are people who conceive in times of famine, who are seriously stressed out. But those are different stresses, and those stresses don't seem to negatively impact.
Just as you're talking, as you're talking, I'm listening to you, and I'm thinking, what do you do with your stress of watching people stress? That must be a very stressful job.
Yeah, I come home and I take it out on the dogs, and then fortunately I'm married to a social worker who...
I hope nobody from the SPCA is...
We might have to come and save your dogs.
No, I would never do that. I love my schnauzers. I would never do that. But yeah, we burn out. We do burn out. We fortunately are a group practice, 5 doctors, and we're able to de-stress amongst each other. But we are fully aware of it, and it can be an extremely taxing day when you go through 18, 20 patients. Fortunately, you know, when I started back late 89, early 90, we had a pregnancy rate of about 2%. So you sat in your hot seat trying to explain to the patients why they didn't conceive. And that was after an embryo transfer where we admitted them for 4 or 5 days, and we had their head down and their legs in the air, and there was a matron who shouted at them if they coughed, sneezed or laughed, and they had to do bladder and bowel actions in a bedpan. They weren't allowed to move, and we had a 2% pregnancy rate. And the only thing that happened to those patients is they got severe headaches because their brain was full of blood from lying head down. You know, today we have somewhere between 65 and even up to 80-90% pregnancy rate. So you don't sit in your hot chair as often as you used to. And that has made a big difference for us.
Right.
That's absolutely incredible.
We're talking to Dr. Lawrence Gobetz. If you'd like to ask the doctor a question or you have a comment, it's 34519. That's our SMS line, 061-895-1019. Dr. Gobetz, can we talk a little bit about PCOS? Because it seems like every single teenager and every young woman walking around today has this condition. Is that a fallacy? Is it something that affects infertility? What's the story behind PCOS? And maybe give a definition and explain it in the first place for those who don't know what it's all about.
Yeah, I think it's a highly overrated thing on the one hand. On the other hand, PCOS is a syndrome. And you have to have 2 out of the 3 things. And firstly, you have to have the ultrasound appearance. Now, a lot of girls are walking around with very healthy ovaries, and unfortunately, the gynecologist puts a probe in and says, you got PCOS, instead of saying, you know what, you got really good ovaries, and your husband's going to have to pay a lot more in Goonies Labola for those ovaries. So it's completely overrated. Secondly, so besides having that appearance on ultrasound, you then have to have androgenization. So you have to have bad skin, you have to have male hair distribution, so abnormal hair in a male distribution. But I'm talking not lanugo. Lanugo is those baby hairs, which are genetic, okay? Your mother will have them, your baba will have them. That is not part of polycystic ovaries. You have to get to a stage where you are actually going to have to pluck out the black hairs, or you're going to have to shave. And then the final thing is you have to have elevated male hormone levels. So the majority of these young girls who've got beautiful looking ovaries are scanned by a gynecologist who has nothing else to do but make sure that the patient leaves the office with the diagnosis, so that the doctor feels that the patient's, you know, he's earned his money, or she's earned her money. So it's so overrated. And I mean, if you look at the incidence in the population, what you're telling me that 100% of young girls have got PCOS is wrong. It's a very low incidence in the general population. So polycystic ovarian syndrome. There are classifications, and there are international classifications. And the majority of these people that are told they got PCOS, they haven't got PCOS. So at the end of the day, it is a syndrome. It is a condition that in most cases, if you have a genuine polycystic ovarian syndrome, it's often associated with anovulation. So those patients either don't menstruate or they have very irregular menses, and it's not something to hassle about on the one hand, because if you do have polycystic ovaries, in inverted commas, the best treatment is, do you want to fall pregnant? If it's yes, go to a good fertility unit. If it's no, get on the contraceptive pill, provided there are no contraindications to the pill. So that's how you manage it, And the other thing is, there is a direct correlation between the BMI, and that's the body mass index, or one's weight, and carbohydrate intolerance. And often when patients go above a threshold, it then falls into place. So it is an endocrine problem. But don't go to an endocrinologist to have it managed, okay? You really just need to go and take yourself off and go and get a good consultation from a good fertility specialist, and it'll all be put into perspective, because you get all this stuff. Are you suffering from PCOS? You don't suffer from PCOS, okay? It's a metabolic thing. And what's more important is that patient gets the right dietary advice and loses weight. But then it's so heterogeneous that we also get the asthenic polycystic patients who are classically thin as a rake, okay, but they have the full-blown symptoms together with, if you put it all together, they form the syndrome. So it is so heterogeneous, and unfortunately the diagnosis is brandied around like, it's like, what about it? You got PCOS, you got PCOS, you got PCOS, everybody's got PCOS. It's nice because then you can WhatsApp your friend, or you can get onto Facebook and you can change your profile and say, I'm a PCOS lady and I'm suffering from PCOS. In this country, everyone's suffering, So I would be careful with that.
We're talking to Dr. Lawrence Gobetz about all things fertile and infertile. We're going to take a little bit of an ad break and we'll be back shortly.
This is the Healthy You, Wealthy You show with Aidel Kazilsky and Faygie Sztern.
We are discussing infertility, and I think one of the big questions today, Dr. Gobetz, is the vaccine. Can we get into that almost yearly discussion? If you are looking to fall pregnant, or you are in that age gap that you're going to want to have a family, how safe, or what would you say to somebody if they said to you, now, Dr. Gobetz, should I get the SARS vaccine?
Yeah, we get calls every day, we get emails every day, and I think that there's a lot of directives out there. The American College of Obstetricians and Gynecologists, the Reproductive Medicine Society of America, the European Society, Human Reproduction, and I always say, firstly, fear the virus, not the vaccine. I think that's very important. Number two, if you're going to do IVF, get the vaccine. If you're going to fall pregnant, get the vaccine. If you are pregnant, get the vaccine. It is not a live virus, okay? It is not a live virus. So, and I always say mothers make babies, all right? But you don't get the vaccine and you do contract COVID and you do have a storm, you lose both mother and you lose a wife and you lose the baby in the patient. So, at the end of the day, it is safe to vaccinate women who are wanting to conceive, and it's even safe to conceive. It's even safe to vaccinate in a pregnancy.
Right. So all this talk about that this vaccine can cause infertility. Is there insufficient evidence against this now? Is it proven to sit and wait or not? You have no qualms about it.
It's a Bobomasis. Bobomasis.
Okay.
Aidel, do you know what a Bobomasis is?
I do know what a compromise is.
Dr. Gobetz, I'd like to ask you though, like when we get so many opinions, Aidel and I, we like to search for the truth. We go from one person to the next, and we obviously get a lot of information from different people, and we try and put the pieces together. When it comes to fertility and someone going to a gynecologist and saying to them what's wrong with me, and like you say, when it comes to PCOS, you've got PCOS, now the person goes home, believes that they have PCOS and believes that they can't fall pregnant, but really they actually don't. How do you as a doctor deal with other doctors' misinformation with a patient? And also, I'm sure it takes a long time for the patient to find someone like you to come and get the actual answer.
Well, patients, I always encourage patients to read up about their conditions, because often patients will come to you knowing more about the condition than what the gynecologist knows. And the interesting thing is, and it's unfortunate because we are faced with this every day, and the patient comes into us with the gynecologist having scanned a year ago and told her that she's got PCOS or PCOS, and we put a scan machine in, look at her antral follicles, and this lady's like maybe half a year away from going into the menopause, and she's got hardly any eggs. So unfortunately, you're either passionate about what you do and you realize your limitations, and you actually, if the patient has a problem and the problem is infertility, you let the patient go to a good fertility clinic. You don't try and manage it yourself. But to beware of labeling patients with a condition that they don't really have. I cannot take responsibility for my colleagues, but unfortunately, we see that every day. And the only way that we can put it across is to say, listen here, my dear, this is what your problem is. It's very easy to say, don't take the Mercedes to the Volkswagen garage for a service. Take it to the Mercedes garage for a service. but at the end of the day, we see this every single day of our practice. And we are 5 doctors in our units, a group practice, and we see many, many patients. And unfortunately, fertility units are sort of known as the end of the road units, and that if you're going to fertility unit, they're going to put you on an IVF program. We don't work like that. The patients in South Africa are very fortunate, because in America, if you go to a fertility unit, it's just for IVF. In this country, it's not just for IVF. It's to sort out minor problems and get you pregnant with the easiest and basic way of doing it. Yes, you have your absolute patients who need IVF. They cannot do it any other way. But interestingly, we sit with this problem every single day. Not only that, we sit with patients having unnecessary surgical procedures that end up causing the infertility. Okay, so patients who have surgical procedures where the doctors go in and things are done in that pelvis that are now causing scarring from the surgery, and now we have to do IVF. Or they go in and they do inappropriate uterine surgery and cause scarring in the uterus, and now we have to go and fix that. So patients must be aware that if they have a fertility problem and the regular general gynecologist is telling them something, do me a favor, go and get an opinion from a fertility clinic. We are living in 2021 now. We are not living in 1820. So be aware of the fact that when you go to a fertility unit, you're going to be slapped on an IVF program immediately.
So I think people just have to kind of get rid of that stigma in their brains and just know not to have that fear of coming to a fertility clinic and do it the right way to start with.
Faygie,
I think it's a big message. People have to understand.
Absolutely. And I think you mentioned a very big word, stigma. Okay. And we need to appreciate that fertility or infertility is no less of a disease than tonsillitis, than whatever other condition, appendicitis. And unfortunately, the stigma stems right back to biblical days. Okay, so that stigma still lives with us today, and we need to overcome that stigma for a patient to know. And you know what one of their biggest fears is that they'll walk into our waiting room and bump into someone that they know who they haven't told that they have a fertility problem. Because anyone who's in our waiting room is there for one reason. You know, you're not there to have your ingrown toenail managed. So at the end of the day, that's one of their biggest fears. And they need to understand that, you know, sharing is caring. And there are many people out there that have the same problem that you have. And it's not a stigma. And it's something that I think that's such an important thing, because yes, it is something that is it's kept private, understandably, because it is something intimate between, you know, husband and wife, or between the couple, and that does, I think that fuels into the anxiety, you know, and then you get the peer pressure of people having babies around you and not talking about it, and then what's wrong with you, you know. And I think that maybe, you know, more education, you know, to people out there to actually understand, as you have said, that it's an illness as much as there's other illnesses. You don't feel bad going to, you know, the orthopedic because your leg's crooked, or the cardiologist because your you know, heart's not ticking right. Correct.
But even more simple than that, I think that also just have people understand that it could be something simple that needs to be corrected. Yes. It doesn't have to be something major. And we all have this fear of this diagnosis, this major diagnosis. I'm going to Vitalab and they're going to tell me such and such, when it could actually be something as simple as falling pregnant the next month. But we just have that anxiety and fear of being in that waiting room.
Yeah, we have to try and overcome that. And, you know, one says, well, what about support groups? And interestingly, you get some really avid patients who achieve a pregnancy and then they start a support group. And then eventually they lose interest and the support group falls away. And I just think today with WhatsApp groups, etc., you know, we should be supporting each other. I'm saying we, the patients, should be supporting each other. And to find your best friend in the same waiting room as yourself is not a skanda, you know, and then gives you an opportunity to share it with you.
Right. We're just going to go for a little break. Time is running out. We'll be back shortly. This has definitely been a very fascinating and, I must say, eye-opening discussion in just blowing away the myths of infertility. I actually have a number of questions that are coming in, and maybe Dr. Gobetz, we're going to have to pull you back again from your busy schedule to help us understand. Let's just sum it up. You know, if you had a message to give out to people, what would that be?
The message would be, number one, don't see it as an embarrassment. Number two, if you have a fertility problem, go to a fertility clinic. Don't stay with your regular gynecologist, because they are gynecologists who deal with all the general stuff. Rather just go to your fertility clinic and get the right opinion and get the right treatment.
Right. Okay. And that's great. If there are people who are wanting to contact you, how can they contact you?
So you can get to us on our website, www.vitalab.com. You can also get to us via Facebook, also it's also vitalab.com. We're on LinkedIn as well as vitalab.com, and the telephone line is 011-911-4700. I repeat, 011-911-4700.
Thank you so much for your invaluable time and for all your expertise. This is certainly something that I know that, you know, I've certainly met people who are struggling in this area. This does give us hope. And what is absolutely amazing when we do have these discussions is that I'm always in awe of modern technology and what can be done today to help people in this area. So, as you said, we're not living in the 1930s or, you know, in a time where we are going in blind. There is a tremendous amount of help out there, and we encourage our listeners not to be embarrassed, not to be shy, and to ask the right questions and get educated properly in this area. So thank you again for your time, Faygie. It was great to be back. And
thank you, Aidel.
Looking forward to many more Healthy You, Wealthy You programs, where we are trying to help educate and trying to educate ourselves, educate you there out there on things healthy, because it is our greatest wealth. Have a great day ahead and a Purim Sameach to everybody out there. Thank you, Doctor. Thank you, Faygie.
It's a pleasure. Thank you.